So currently we're on day 7 of the 70 days leading up to the GPhC exam. So we've covered a lot of different topics so far. What I want you to focus on for day 7 is the central nervous system, in particular the topic relating to dementia. If you're a member, you've got access to all of these videos. If you're a non-member, then these are the topic areas that I want you to focus on. So first thing is I want you to go through an introduction to dementia, and then I want you to go through an introduction to the treatment for dementia, go through donepezil, rivastigmine, galantamine, imantine, treatment principles, other dementia types, and I also want you to go through behavioral and physiological symptoms associated with dementia and summarize all of that knowledge that you've gone through. I will include some dementia videos in this just to give you an understanding of the level of detail I want you to go through for revision. And then I want you to focus on the pain aspect of the central nervous system. So an introduction to pain, consider paracetamol, NSAIDs and opioids. And then calculation pack 4. Calculation pack 4 contains 10 calculation questions. If you're a member, you have access to the pack. If you're a non-member, I want you to work through 10 calculation questions. I want you to use varied examples from the 12 calculation questions that can come up in the GPhC exam. What I will do also is include a video in this series of one type of calculation question. So I want you to go through CNS, dementia and pain. Where should you be in terms of your vision? You should be much more confident when it comes to infection and endocrine system. We've also touched on blood and nutrition. We've done a lot of calculation questions and we're doing CNS content today. What I'm going to do for tomorrow's video is I'm going to have a series of questions relating to the infection and endocrine system chapter so that I can test your knowledge at that point. If you struggle to answer those questions, this is an indication that you need to revisit those topics.
This teaching is on dementia, which is the first part of chapter 4 in the BNF, the central nervous system chapter, which this series by myself will focus on. So the GPhC have highlighted in the framework that chapter 4 of the BNF is a high-weighted topic, which means it's more likely to feature in the exam. And the GPhC have defined high weighting as being 60 to 70% of the questions. These are the main aspects that we'll go through. I've tried to tailor the content to what you'll need to know for the exam. This is a specialist area, so you're not going to be expected to have a detailed understanding of everything to do with dementia. But having a basic understanding of the pathophysiology will help you understand the treatment used. I'll focus more on the treatment and treatment pathways, briefly covering diagnosis and assessment. So what is dementia? Dementia is a syndrome, which means a group of related symptoms. And overall, it's a decline of brain functioning. It's progressive and degenerative, and currently there isn't a cure. So treatment focuses on slowing down the progression and trying to reduce symptoms. And with dementia, there are some key symptoms. The most known one is memory loss, but there's also a cognitive decline, slower thinking, slower understanding, poor judgment, things like that. It can also cause a change in personality, for example, more aggression. And people with dementia can lose interest in their normal activities or have issues managing and regulating their emotions. There can be an impaired ability to communicate, for example, using words incorrectly. So they might want to say table, but they say door instead. Or they just might have general trouble speaking. As dementia progresses, there's a loss of skills. For example, being unable to wash, dress, cook, and people can have problems with movement, which again affects their ability to carry out those types of skills. And also people with dementia can experience hallucinations. So this slide just demonstrates how common dementia is, mainly in the older population. It's estimated that more than 850,000 people in the UK have dementia. 1 in 14 will be over 65 years, and 1 in 16 will be over 80. Early onset dementia can occur. Around 1 in 20 people with Alzheimer's are younger than 65 years old, which might be more than you'd expect. And as the aging population grows, the diagnosis of dementia is going to increase. And it's estimated that in 2 years' time, over 1 million people will have dementia. So I mentioned that dementia is a syndrome. It's an umbrella term. There are different causes of dementia, or disease states themselves, and I'll briefly talk about the two most common ones. The most common is Alzheimer's disease, which accounts for around 60 to 70% of cases, and is thought to be caused by the abnormal buildup of proteins in and around brain cells. Amyloid is one of those proteins, which you might have heard of, and it forms plaques around the brain cells. The second one is vascular dementia, which accounts for about 20% of cases, and it occurs because of reduced blood flow to the brain. Patients who have had a heart attack or stroke are at a high risk for this type of dementia, but because of the potential causes of this dementia, there are some modifiable risk factors. For example, smoking, hypertension, high cholesterol. The other two types of dementia are a lot less common. Body dementia accounts for about 15% of cases. Temporal dementia is even less common at less than 5% of cases. There are also other conditions that can cause dementia, which are listed on this slide. Dementia is quite common, and I'll go into which medication can be used in this particular type of dementia a bit later on. This graph nicely demonstrates how slow the progression from mild Alzheimer's disease to severe Alzheimer's disease can be, potentially over 5 years or even longer. So in the first few years, people may experience signs of mild cognitive impairment, things like losing their train of thought more often, difficulty following a conversation or finishing tasks. After around 2 or so years, more symptoms start to present themselves as listed on the graph there. Symptoms like increased forgetfulness or short-term memory loss. They ask repetitive questions because they've forgotten what they've asked. Anomia, which is the last one, that section there, means difficulty finding words. So this is when mild Alzheimer's disease may be diagnosed. And from 5 years onward, the Alzheimer's starts to progressively worsen with more severe symptoms. And this graph spans over 9 years, but the progressive decline might take even longer in some people. I'll briefly go over the assessment process for dementia, just for your understanding. So there isn't a single test for dementia. It's quite a thorough process for diagnosis. Detailed history is required first, and this will go into a patient's background, including medication and any physical health diagnoses they might have. It will also go into what they were like in terms of personality and a timeline of their symptoms. And this can be done by a GP or a specialist. Cognitive assessments test the mental ability. The MMSE, which is the Mini Mental State Examination, is very commonly used to assess the level of cognitive impairment. So it will ask things like, do you know where you are, what year it is? It will also ask some basic maths and language competency. The MMSE is also used in psychiatry to test capacity and cognitive function in the context of mental health. The ACE-3, which is the Adam-Brooks Cognitive Examination, is a bit more sensitive to dementia. It tests things like attention, memory, visual perception, and spatial skills. And you can look at the NICE guidelines to see what other cognitive assessments are suggested, but you'll only need to be able to recognize them in your exam. Neurological examinations are also key to show any changes to the brain. And blood tests are important to ascertain the overall well-being of the patient and to rule out any other causes for the symptoms the patient is presenting with. Blood tests include things like thyroid function, B12 and folate, glucose, etc., because these things can affect cognitive function. And the severity of dementia that's diagnosed will depend on the level of cognitive impairment, and that indicates which treatment should be used, which I'll go into. So just to very briefly touch on pharmacological treatment options, is mainly psychological therapy. What's also important in dementia, they have mild to moderate dementia, then they should be offered these supportive psychological type therapies, sorry. Again, this slide is just sort of more for your understanding. Pharmacological management of dementia on 2 treatment pathways, and I'll go into more detail on the next few slides, but the aim of treatment, as I mentioned before, is to boost the functioning of the neurotransmitters that are implicated in dementia, therefore delaying the progression and managing any sort of behavioural or psychological issues that are associated with dementia. I've listed the drugs there, which fall under the 2 pathways, and as you can see, 3 out of 4 of the drugs used in dementia work on the cholinergic pathway, only 1 works on the glutamate pathway. So the cholinergic pathway is what I'll go into first. It's important for signalling and communication between neurons, as well as physiological functions like slowing down the heart rate or regulate blood pressure. So acetylcholine is a really important neurotransmitter, and it also acts on muscarinic receptors. The M1 receptor is important for memory, attention, and motor control. Acetylcholine also acts on nicotinic receptors, some of which also regulate cognitive function. So acetylcholine is degraded by acetylcholinesterase enzymes and also degraded by butyrylcholinesterase enzymes. And these enzymes ensure that there isn't an excess of acetylcholine circulating in the brain. However, a loss of those neurons and reduced levels of acetylcholine is what causes that cognitive impairment. It's not known exactly what causes that degradation or reduced levels of acetylcholine, but there are a few things that might. So, for example, there may be increased activity of the acetylcholinesterase enzyme, which reduces the levels of acetylcholine, or like in Alzheimer's disease, the formation of amyloid plaques. Similar to Parkinson's disease, by the time people with dementia experience mild symptoms, there's already a significant acetylcholine deficit, and levels eventually reduce by 40 to 90% in moderate to severe Alzheimer's disease. So make sure you have a look at the NICE guidelines for the pharmacological management of dementia. They break it down quite nicely. Acetylcholinesterase inhibitors are first line for mild to moderate Alzheimer's disease. They should be initiated by or on the advice of a specialist, and it can be initiated in primary care. If a patient with Alzheimer's disease is already on an acetylcholinesterase inhibitor, then memantine can be started by a GP without the advice of a specialist. It just depends on where that patient sits in the treatment pathway. And these drugs shouldn't be stopped just based on disease severity. So NICE recommends essentially using the cheapest option, which is donepezil currently. The patient doesn't tolerate that well, or it's not suitable for some reason, then others can be trialed. So this slide just sort of shows how acetylcholinesterase inhibitors work. So they target the acetylcholinesterase enzyme by blocking its action and therefore increasing levels of acetylcholine. By blocking the enzyme, also allow acetylcholine to circulate in the brain for longer. These drugs are more effective in the early stages of Alzheimer's disease because there are more postsynaptic acetylcholine receptors present. And as the disease progresses, there's a loss of acetylcholine and its receptors, as I explained, so therefore the drugs are just not going to work as well. So before I go into the properties of each drug in this class, I want to briefly mention anticholinergic burden. Strong association between anticholinergics and cognitive impairment, especially in those aged over 65 years old. Already mentioned the 2 receptor types that acetylcholine acts on, muscarinic and nicotinic. Antimuscarinics are very commonly prescribed. Nicotinics, which block nicotine receptors, are less commonly prescribed. A common example of an anti-nicotinic is dextromethorphan in some cough syrups. So as I said, antimuscarinics are used in a variety of conditions: overactive bladder, Parkinson's disease, irritable bowel syndrome, depression. Examples of these types of drugs are things like amitriptyline, olanzapine, oxybutynin, olefenicin, cetirizine. And there are many calculators available where you can input the drugs and get a total score of the anticholinergic burden. It's really important to review these medications generally, especially in the elderly, but particularly in patients with dementia. And if it's possible, they should be stopped, or at least the dose should be reduced. So this slide is just sort of more for your information, medications and their anticholinergic burden scores. Any drugs with a score above 2 or 3, you'd want to be looking at alternatives in dementia. And you'd especially want to make sure that they're not on too many drugs with anticholinergic burden, because even if the score of the drug is 1, means that the total score for that patient can be 2 or 3 or even higher. So this teaching is on pain, which comes under Chapter 4 in the BNF. The GPhC have highlighted in the framework that Chapter 4 of the BNF, which is the CNS chapter, is a high-weighted topic, which means that it's more likely to feature in the exam. The GPhC have defined high weighting as being 60 to 70% of the questions. The GPhC have also highlighted high-risk drugs, and from this particular topic, this includes opioids and parenteral drugs, as opioids can be given parenterally, and NSAIDs. When learning this topic, be aware of the rules for OTC sales, because a lot of the medications included in this topic can be sold over the counter, and be aware of what's available over the counter as well. So the main topic areas that I'll cover in this teaching are the principles of pain management, treatment for different types of pain, and any adverse effects and monitoring related to the main drugs. There are some adjuvant medications that can be used, and I've just mentioned them briefly on the last slide. I don't think you need to know them in any particular detail because they tend to be used by specialists, but it's just to be aware of them. So pain is defined as an unpleasant sensory and emotional experience, and it can be associated with actual or potential tissue damage, or symptoms that resemble tissue damage without the actual damage. It's the most common reason for someone to seek medical attention, and it's the body's way of highlighting that something is wrong. But also note that pain can be entirely psychological. And this doesn't mean that it's not real, but it does determine how effective management can be and what management is chosen. So there are different classifications of pain. Nociceptive pain is the most common type of pain, and it occurs in response to a painful stimulus. It can be somatic, which is where pain receptors in the muscles, bones, or soft tissues are activated, or it can be visceral, which occurs when the internal organs and blood vessels are inflamed, damaged, or there's some sort of disease. Radicular pain is a type of pain that radiates from the back and hips into the legs through the spine, and it's usually due to a compressed or inflamed spinal nerve. And then this type of pain can vary in how it feels depending on the cause. So it can be sharp, aching, or throbbing. And examples of this type of pain would be things like the pain you get when stubbing your toe, or abdominal pain associated with hepatic impairment. And then there's neuropathic pain, which stems from the nervous system being damaged or affected in some way. Examples of this type of pain are trigeminal neuralgia or diabetic neuropathy. And this type of pain can be quite difficult to treat, and the medications used are a bit more on the specialist side. Nociplastic pain is still not completely understood, but essentially it's when there is sensitization to pain or altered pain processing. It's a relatively new type of pain in terms of its definition, and it was termed in 2017. It's due to altered nociception, which is the first type of pain that I mentioned, without any actual damage to tissues or bones or muscles. So examples of this type of pain would be fibromyalgia, which is sort of an all-body pain that patients can experience. or pain in irritable bowel syndrome, where there isn't actually any damage. And again, this pain can also be quite difficult to treat. And then within these different types of pain, pain can be classified as acute, which is sudden and usually sharp or intense in nature, or it can be defined as chronic, which is when the pain has been ongoing for more than 12 weeks. Acute pain management depends on what's causing the pain, and chronic pain management also depends on the type of pain, but usually treatment plans will be a mixture of pharmacological and non-pharmacological treatment. People with depression commonly have chronic pain. It can be sort of a comorbid diagnosis, and it can actually be a trigger for suicide. So these are some of the non-pharmacological options that can be used in the management of chronic pain. Because it's long term, there's also advice on self-management, because again, medication can only take things so far, and depending on the medication used and the type of chronic pain, that will determine sort of how effective the pain relief actually is. So it's important to have some non-pharmacological options. Also, analgesics come with side effects as well. So if someone has chronic pain, they're going to be on this medication for a long time. So having non-pharmacological options avoids that sort of side effect burden or reduces it. And it's important to remember that chronic pain can be very, very debilitating. It can affect people's mood, the way they function in life. Some people can't go back to work. So it can be quite difficult to manage. So the WHO pain ladder was originally designed to manage pain from cancer, but it's been widely adopted for other types of pain, and it's still sort of the go-to for managing pain, whether it's acute or chronic. There actually isn't much evidence to support its use in chronic pain, but the general principles are useful when thinking about starting someone on pain relief medication. So initially, you start with a non-opioid, which could be paracetamol or an NSAID, and then you'd move to a weak opioid or another non-opioid, potentially with something else, if the pain is still there, if it's increasing or it's persisting. And then the third step is for moderate to severe pain, which would be a stronger opioid with or without a non-opioid and something else, maybe an adjuvant. And the WHO pain ladder can be a good basis when you're reviewing someone's pain medication. So if you've got someone who's been put on codeine and maybe they're experiencing side effects, or you're rationalizing their medication, maybe they're on other CNS medication, you'd want to check whether they've actually tried regular paracetamol first, whether it's appropriate for them to have an NSAID before you move up the pain ladder.
Right. Hello, everyone. My name is Nkatia. I'm one of the clinical educators for calculations on the MicroPharm platform. And in today's session, we're going to be looking at dilutions. In all honesty, I think tackling dilutions is always a little bit of fun, and I'm fairly certain I can hear most of you groaning at the idea of me going over dilutions. Or you may be celebrating because now you're finally going to understand dilutions. I won't lie to you, I think in terms of personal experience and uh, other experiences from trainees that have rotated through my trust, or working with other trainees, dilutions is definitely one of those areas that is always talked about as being really, really challenging. And again, what I'm going to say here is that the success to dilution questions is again just trying to imagine what is going on. I'm really going to break down dilutions. So by the end of this, I guarantee you, you will understand dilutions more than you do now. So get a pen and paper, get your calculator, because we're definitely going to learn about how to tackle dilutions today. But before we get into the actual nitty-gritty of it, the first thing I'm going to remind you is that your success with regards to the calculations component of the registration assessment always comes back to understanding the questions. Know your question types. Each assessment is likely to include at least one calculation question involving each of the following in part 1. The other thing that I will stress to you as well is that calculations are part of a pharmacist's day-to-day life in many different forms, and they are by no means impossible, whether you're in primary care, secondary care, tertiary care, or even cross-sector. You've done all of these calculations before as an MPharm student and were successful. There is no reason why you can't be successful with the same question types now. Remember your time management. Remember to think about the context of the question. Remember, this is a pharmacy practice assessment in the prism of calculations. And remember to break down the question. Really highlight the sections that you think are of importance to you so that you stay on track to answering the question. And without further ado, let's jump right into it. When we think about dilutions, I think a good place to start is thinking about what a dilution actually is. Okay, and I don't mean a type of question that everyone dislikes. Dilutions involve making a solution weaker by adding more solvent. Now, a really good example that I'm going to use, and you know what, I'll do it live because there's no harm in doing so. So I have some blackcurrant and apple squash in this glass here. And what I'm going to do is I'm going to add a little bit of water. And in adding that water, you can see that now it's become a lot lighter. I did also do that because I fancied a drink. So what we can see is that that's a great example of diluting a drink. We had a concentrate, which you can think of as a stock solution, and we added a solvent to make it more dilute. So let's say in that little bit of blackcurrant and apple squash, I had 5 grams of sugar. Let's just say as an example. What I've done by adding the water is I have almost spaced out the volume in which that same 5 grams are spread. So I've not added any more sugar, I've just spread the sugar out in a much larger volume. Now, there are many reasons in which you might want to dilute something. You might want to dilute something for a certain viscosity, for instance. If maybe a solution is too thick, you might want to add a little bit of water. Okay. For parenteral administration, you might need to dilute something because it would be a vesicant or an irritant if you tried to administer it at a much more concentrated, well, at a higher concentration. Now, dilutions are also quite challenging because there are loads of different numbers involved, or sometimes you'll have differing units within the same question. So, with the question that we're going to go over, we're really going to take our time with it and really break it down. And I'm going to explain all the different things that I think students often find difficult with dilutions. So, let's have a look at the question. What volume of a 0.5% weight per volume stock solution is needed to produce 1 litre of a 1 in 8,000 solution? Pause the video, give yourself 3 minutes. When time is up or when you're ready to go through the answer, I want you to press play. Okay, I think we're good to get stuck into the question. Now, I think the first thing to point out here is that we've got loads of different units. And so it would be worth thinking a little bit about what these units mean. Anytime you see percentage weight per volume, that's the same as saying, well, how many grams you have in 100 ml. So 0.5% weight per volume is the same as saying 0.5 grams in 100 ml. Similarly, if you see 1 in, let's say 8,000 in this instance, that's the same as saying 1 gram in 8,000 ml. So with these types of questions, I always like to sort of just write out or scribble what the converted form is so I can work with the same units because it just makes life a lot easier if we can convert to the same units. Remember in your registration exam, you still have access to a little whiteboard, which you can take in with you, or a whiteboard that they will give you. So by all means, make use of it. Make use of spare paper they can give you if needs be, if it helps you convert between the different units. Now, 0.5% weight per volume is the same as saying 0.5 grams in 100 ml. 1 in 8,000 is the same as saying 1 gram in 8,000 ml. Now, what I wanted to do was I wanted to convert the 1 in 8,000 to a percentage. So then I can work with the same units as I did with the 0.5. So in order to do that, I divided both sides by 80. So 1 gram in 8,000 ml is the same as saying 0.0125 grams in 100 ml. which I can then say is 0.0125%. And then I can use my good old equation C1V1 equals C2V2. Now, the way that I've always understood this equation is saying that the certain concentration and volume of one thing equals the concentration and volume of another thing. So let's say, for instance, to make everything equal, I use a lesser concentration, okay? Um, Chances are I'll need a much larger volume in order for the actual amount of substance to be the same. Because that's all I do with a diluent. I'm just adding more solvent, similar to my water, and then I'm spreading out the same amount of actual substance in a much larger volume. So by using C1V1 and C2V2, I can then rearrange it to make V1 the subject, because in this instance, I want to know what volume of the stock solution I needed to produce 1 liter of a 1 in 8,000 solution. So in this instance, when I rearrange it to make V1 the subject, that would imply that V1 equals C2 times V2 over C1. C1 is 0.5, C2 is 0.0125, and V2 is 1,000 mil. Okay, because I wanted 1 liter. Also remember that your units need to be the same, so that 1 liter we're going to convert into milliliters. So that gives me an answer of 25 mil. So I need 25 mil of stock solution. If I then added 975 mil of solvent, whatever it might be, let's just say it was water, I then get 1 liter, and that 1 liter has a concentration of 0.0125%. Now, in some questions, you may be asked what volume of diluent do you need, in which case you're only adding on one extra step here, where you would subtract that 25 mil from the total volume of the solution in order to figure out how much diluent you would add. Now, hopefully that makes sense. Um, like I said before, dilutions is always a very, very difficult area, but if you break down the question and you really make sense of it, what you'll find is that dilutions aren't that difficult at all. Just imagine you're pouring blackcurrant in apple squash or orange squash, whatever your preference is. But that's all from me as far as dilutions go. Hopefully that makes a lot more sense. If you do need any further support, just remember the MicroPharm team are here to support you, and I wish you all the best for your revision for the registration assessment.